Okay, so this is the start of our head to toe physical assessment for NU 333. Hi there, how are you doing today?
Good.
Good. Is it okay if we go ahead and go through a full head to toe assessment today?
Yep.
Alright, I'm just going to start off by taking some vital signs. I'm going to get your blood pressure. Okay, good. It was 108 over 78, which is perfectly normal. And I'm just actually going to check it on the other side too, just to compare bilaterally. And 110 over 80 on that side, so that's great. Also, as part of head to toe physical assessment, I've already weighed this patient, got this patient's height, and calculated his body mass index. And those are all recorded in the proper location. So I'm just going to go ahead and start my head to toe physical assessment. There's a couple of things just by looking at the patient that you're able to tell. I can tell that his affect is calm and pleasant. The patient was smiling when he walked in. When I greeted him, he was able to articulate clearly his speech, is able to hold a conversation with me. I can also note his skin color looks great. There's no excess sweating, anything like that. And I'm just going to go ahead and start by palpating the patient's skull, making sure that it's normal cephalic and that there's no abnormal bumps or lesions, anything of that sort, and it feels fine. I'm actually just going to bring and palpate all the way down the regional lymphatics in the neck. And when you're doing that, you're looking for any sort of swelling or tenderness. Did you have any tenderness at all when I was palpating there?
Nope.
Okay. So I'm going to go ahead and do my assessment of the patient's eyes first. You test the cranial nerve number 2 can be used, it's the visual acuity. You use a Snellen chart to test that, and the patient was able to read the chart from a distance, so he has no problems there. 20/20 vision in both eyes. And then I'm also going to test the cranial nerves 3, 4, and 6, making sure that his pupils are equal and reactive. We use a pen light for that. So go ahead and just focus your eyes behind me. Great. And both of his pupils are equal and reactive to light bilaterally, so that's great. And then I'm going to have the patient focus on the object here, just with your eyes. And I would also note that the patient's pupils are equal and reactive to accommodation as well. I'm also going to check the cardinal fields of gaze. So go ahead and, without moving your head, just follow my finger with your eyes, okay? Okay, great. The patient was able to follow my finger with both of his eyes without moving his head, so that is great for that. And then I'm also going to have the patient cover, go ahead and cover your right eye. And I'm going to, when you see my fingers move, not my hand move, tell me, just say now, okay?
No. 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 No.
Okay, and go ahead and cover with the other eye and do the same thing.
No. 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 No.
Okay, great. And that tests the patient's peripheral vision also. The next thing I'm going to look at with the eyes is just with an ophthalmoscope, you would observe the disc of the eye. I don't have one of those, but on a normal physical assessment, that's what you would do. I'm going to look at the patient's eye and look at his sclera, making sure that it's white and there's no yellowing or grayish hue or any abnormal tint. Should be pearly white, which it is, so that's great. Also looking at the conjunctiva of the eyes, making sure that it's pink and moist and there's no extra drainage or discharge at all. Making sure always to do so bilaterally. And that looks great. You can also look to see if there's any ptosis of the eyelids, which is drooping, and there's not, so that's always good. The next thing I'm going to assess is the patient's sinuses. So his frontal sinuses can be palpated just below the eyebrows here. Do you have any pain or tenderness when I palpate?
No.
Okay, and then the maxillary sinuses can be palpated just below the cheekbone here. Any pain on
No.
palpation? Okay. So we're going to go ahead and assess the patient's nose next. Using a light, making sure that the turbinates in the nose aren't swollen. There's no redness. Making sure that the airway is clear. Go ahead and cover one nostril and have the patient breathe through the other. Good. Good. And if you heard any obstruction or anything like that, you know, the patient might have excess mucus, anything like that. The next thing that we're going to assess is the patient's ears. Use the light for that also. Just making sure that there's no discharge drainage, no tenderness on palpation, no abnormal lumps or nodes at all. A lot of times patients have excess crumen in their ears, which can lead to problems with hearing, so making sure that there's no excess earwax is also really important, and making sure that you do that bilaterally. Also, we're going to assess the patient's mouth. Looking at the lips, making sure that they are symmetrical first of all, making sure that they're pink and moist, which they are. Going to go ahead and have the patient open his mouth. Making sure that the mucous membranes inside are also pink and moist, making sure that there's no lesions or sores, anything of that sort, which there's not, so that's great. Also testing some of the cranial nerves. I'm going to go ahead and depress the tongue and have the patient say ah. Say ah.
Ah.
Stick your tongue out. Say ah.
Ah.
Making sure that the uvula in the back is midline and that the soft palate rises symmetrically on both sides, which it did, so that's great. Can I have you protrude your tongue out and move it to the left and then to the right? Okay, and that tests the hypoglossal cranial nerve. Normally the patient should be able to hold their tongue straight midline. If there's any sort of deviation from mid, there might be an indication that something's wrong there. Everything looks great. A couple of other things that we are going to assess, the trigeminal cranial nerve can be assessed. You can have the patient close their eyes and just tell me when you feel something touch your face and where you feel it, okay?
Yep, underneath my eye. Above my eyebrow.
What side, left or right?
Right. Left side above my eyebrow. Left side below my eye. Right side on my chin. left side of my chin.
Okay, and the most important thing there is just making sure that everything is equal and symmetrical on both sides of the face, which it was. Also have the patient clench their jaw as you palpate the masseter here, making sure that the muscle on both sides is equal as the patient clenches. And then I'm also going to have the patient open, and I'm going to feel the joint as he opens his mouth, making sure that everything, once again, is symmetrical. Oftentimes there is a popping or clicking noise that can be considered normal. This patient doesn't happen to have that. The next thing, I'm going to have the patient, I'm going to pull down on his jaw. I'm going to try to pull down on her jaw, but don't let me, okay? That's another way to test the cranial nerves. Everything is fine there. So moving on to the patient's neck. I'm going to start by palpating the carotid arteries. You always palpate one side at a time. Palpating both sides at one time can cause the patient to pass out. We definitely don't want that. So and I would say that this is 2+ normal on both sides, which is great. I also noted any swollen lymph nodes that might be in the patient's neck. He doesn't have any, but anything that you were able to palpate would be considered abnormal. I'm going to go ahead and listen to the patient's carotid arteries for any sort of bruit that may be present with the bell of my stethoscope. And there was no bruise audible, so that's great. The next thing is just asking the patient to swallow, making sure, can you just go ahead and swallow for me? Making sure that there's no problems with or difficulty with swallowing. That's another way that you can assess the cranial nerves. Also, I forgot to do it while we were assessing the patient's mouth, is to assess the patient's gag reflex. If they're able to elicit a gag reflex, that's a good thing. If they were not able to, there may be an indication that something is wrong. Moving on, we're going to go ahead and do the assessment of the chest next. So I'm going to start just by palpating both sides of the chest bilaterally, asking the patient to let me know if he feels any tenderness at all. You feel any tenderness on palpation?
Nope.
Okay, great. And then I come around to the back side of the patient. Do the same thing. Any tenderness at all?
Nope.
Okay, and also while I'm back here, I'm going to ask the patient to lean forward. Okay, put your head down. And then I'm just going to palpate the spine, making sure that the spine is straight, there's no scoliosis present, and that there's no tenderness along the spine at all. Do you have any tenderness at all when I palpate?
Nope.
Okay, great. And then while I'm on the assessing the back of the patient, I'm going to percuss for the CVA for any tenderness. Go ahead. Any tenderness there?
Nope.
Any tenderness there?
Nope.
Okay. Flank pain could be an indication that there's an infection with the kidneys, something of that sort. So it's always important to go ahead and do that. The next part of the assessment, I'm actually going to have, can you go ahead and lay back for me?
Yep.
Okay. I'm just going to lift your shirt up. Okay, so I've already palpated the chest for any abnormal nodes or anything like that, any bumps or lesions, and everything is great. I'm also looking at the symmetry of the chest, making sure that everything is equal on one side to the other, which it is. So that's good. The next thing, I'm going to go ahead and listen to, well, actually, I'm going to I'm gonna percuss the chest before I auscultate. Starting with the second intercostal space. And then I'm going to go ahead and listen to the lung sounds of this patient. Starting at the second intercostal space, that is the aortic valve area. It's not necessarily where the valve is located, but that's where the valve is, the sounds that the valve makes are best heard. So using the diaphragm of my stethoscope, take a deep breath for me. Then I'm going to move over to the second intercostal space on the left side. This is the pulmonic valve area. Take a deep breath for me. Good. And then I'm moving to the fifth intercostal space, midclavicular, to listen to the apical pulse. And the apical pulse is also something that you want to be able to palpate. On some patients, if they're a little bit heavier set, you won't be able to palpate the apical pulse. And if they have a thick chest wall, you won't be able to palpate it then either. So when you are auscultating breath sounds, you're listening for, obviously, your S1 and S2. S1 is heard best at the apex of the heart, S1 is heard best at the apex of the heart. S2 is heard best at the base of the heart. But really you can hear both of those sounds anywhere over the pericardium. I'm sorry, I said that we were going to do the respiratory assessment and I skipped to the cardiac assessment. So we'll go back and do the respiratory assessment in a minute here. And then you're also listening for any abnormal heart sounds that you may hear. I'm listening for any murmurs, any extra heart sounds, S3, S4. Anything like that needs to be noted in your documentation. Okay, going back to the respiratory assessment. So I'm going to go ahead and listen to this patient's lungs. Starting, go ahead and take a deep breath for me. Deep breath. And also with the breath sounds, you're listening for any adventitious breath sounds, any wheezing, crackles, anything like that that could be an indication that there's something going on. Can you go ahead and sit up for me just for a second? And I'm going to go ahead, no, you can stay here, it's okay. And I'm just going to go ahead and listen to the lungs in the back. Go ahead, deep breath. Okay, great. You can go ahead and lay back down. So the most important thing when you're doing that, not only are you listening for the sounds, but you're listening bilaterally to make sure that everything is symmetrical. Oftentimes you can hear crackles or wheezing on one side, but not the other. So it's important to document which side you heard which sounds and which sides were normal. The next part of the assessment that we're going to go ahead and do is the abdominal assessment. So first, I'm just inspecting the patient's abdomen, noting the contour, making sure the abdomen's flat. There's no bulges, anything that looks abnormal. There's no nevi. The hair is evenly dispersed on the patient's abdomen. And when you do an abdominal assessment, it's important that you do all of your everything else and save the palpation for last because that can displace the bowel and cause some bowel sounds that aren't actually there to be heard. So I'm going to go ahead and listen to this, and now that I've inspected, I'm going to auscultate the bowel sounds. And I was able to hear those were normal active in all 4 quadrants. And then the next assessment technique, I'm going to go ahead and percuss over each of the 4 quadrants of the abdomen as well. So over each of the 4 quadrants, it was tympanic, except for over the right upper quadrant. That's where the liver is at, and when you're over a solid organ, you get that dull sound rather than the tympanic sound. So that's why we heard that up there. That's considered normal. I'm going to next do light palpation of the patient's abdomen, asking them to indicate to you if they're having any tenderness at all while you're palpating. Does that hurt? How about that?
No. Nope. Nope.
And the light palpation is just 1 to 2 centimeters. And now we're going to go ahead and do the same thing, but we're going to palpate deep.
Nope. 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 Nope.
Okay. The patient didn't have any pain or tenderness there that he indicated, so that's a great sign. That's a great sign. If you were to palpate the patient's right lower quadrant and they noted that it was more painful when you removed your hand rather than when you depressed, that can be an indication that there's something wrong with the appendix. That's called rebound tenderness, and that needs to be addressed immediately if you were to ever find that. So for the next part of the assessment, I know the patient's laying down, but I'm just going to go ahead and assess his arms. Go ahead. You can just leave him down. It's fine. So I'm just noting the temperature all the way down the patient's arm, making sure that it's normal or symmetrical on both sides. It's warm. There's no temperature change. If there were, that would indicate that there was possibly a problem. I'm going to feel for the patient's brachial pulse on both sides. And that's equal, 2 plus equal bilaterally. I'm also going to test for the lymph nodes in the patient's arm. So by doing this, you shake the patient's hand, and with your opposite hand, you come around in between the triceps and the biceps muscle. You try to palpate that lymph node there. If it's palpable, which it shouldn't be, indication that something's wrong, but it's not palpable, so that's great. And you always do the same thing on both sides. Coming down, going to palpate the patient's radial pulse on both sides, making sure that it's equal and strong. And it is, so that's great. Coming down, I'm checking once again the temperature, checking the skin turgor. That can also be checked on the patient's upper chest. That's a great area to check that. Checking the skin capillary refill, which is less than 3 seconds, so that's normal. Checking that on both hands. And then also, can you go ahead and squeeze both of my hands? Making sure that the hand grasp is equal and strong on both sides is also important. Okay, continuing on down, we're going to move on to the patient's legs. So just like we did with the arms, I'm going to feel down both sides, making sure that the temperature is the same on both sides, that there's no temperature change, that the color is symmetrical, which it is. Palpating for any tenderness, any lumps, any nodes, anything that seems out of the ordinary. Do you have any pain on palpation?
No.
Okay. I'm going to feel for the patient's popliteal pulse. Go ahead and lift this thing also. And I'd say that's 1+ on both sides bilaterally. Moving down the legs, I'm going to palpate the posterior tibial pulse on both sides. And that's 2+, strong bilaterally. And then the dorsalis pedis pulse. And that is also 2+, it's strong bilaterally. Also noting the temperature of the patient's feet, once again, making sure that it's the same on both sides. Checking the capillary refill of the toes, just like you did with the hands. Making sure if you weren't to get a good capillary refill, or if there were to be a change in temperature, that could be an indication that there's a circulatory problem. Another thing you want to assess in the patient is the Homan sign. That can be an indicator. It's a non-specific indicator, but it can indicate that the patient may have a DVT. That's done just by dorsiflexion of the patient's foot and asking them, do you have any calf pain at all when I push back on your foot?
No.
And how about on this side?
Nope.
Okay. So that is good. There is no indication that this patient has a DVT. Also looking for any swelling, redness, tenderness. Those are all indicators of a deep vein thrombosis that the patient might have. Can you go ahead and sit up for me? Okay, so we're going to go ahead and check the patient's reflexes. The biceps reflex. Go ahead and just relax your arm. And the normal response for that is flexion of the bicep or flexion of the arm and a contraction of the bicep. Making sure you do that on both sides, and then checking the triceps reflex. Go ahead and let your arm go dead. And checking that on both sides as well. The next one we're going to check is a quadriceps reflex. So placing your non-dominant hand on the quadriceps and then eliciting a response. And you should feel a contraction of the quadricep on both sides. And you should have extension of the feet. Looking for hypo or hyper reflexes is really important. That can be an indicator that there's something going on. Go ahead and stand up for me. And go ahead and face that towards the door. And put one foot in front of the other. Close your eyes. Okay, so this is called the Romberg test, and the patient had a little bit of trouble standing straight, but the patient should normally be able to stand 20 seconds with his eyes closed with no problem. Sometimes there's a little bit of swaying that can be considered normal, but and then have the patient bend one knee and hop while your eyes are closed. One hop, and with the other leg. Okay, that is called the Romberg test. Go ahead and walk towards the door for me, one foot in front of the other. Okay, and come back. Okay, so you're just assessing the gait and coordination of the patient. The patient didn't have any problems with coordination. He was able to walk. He doesn't have to use any assistive devices at all. His gait was steady. This indicates to me that there's no neurological deficits in that area at least. Go ahead and have a seat. We've pretty much gone through our whole head-to-toe assessment. Yeah, I think that I've gone through pretty much everything. If there were something that were to be forgotten, it's always good, even though it's out of sequence, to go back and to do that, then to completely omit it from the assessment. But for now, that completes our head to toe assessment for NU 333. Thank you very much.